SRM Institute of Science and Technology. Learn, leap, and lead.
Good morning, everyone. Welcome to the Future Career Conversations webinar series presented by the Hindu and the SRM Institute of Science and Technology. Today's session is on public health in India, from reactive care to preventive ecosystems. India's healthcare system is steadily shifting from treatment-focused care to prevention-led systems. And in today's discussion, we'll explore what this shift means in practice, the role of data and policy, and the opportunities emerging in public health. We have a panel of experts with us today to help unpack this and share their insights. We have Dr. Hari Singh, Dean, School of Public Health, SRM Institute of Science and Technology, Dr. Soumya Swaminathan, Chairperson, MS Swaminathan Research Foundation, Principal Advisor, National Tuberculosis Elimination Program, Ministry of Health and Welfare, Family Welfare, Government of India. We have Dr. J. Amalol Pavanathan, Member State Planning Commission, Government of Tamil Nadu, former Director, Institute of Vascular Surgery, Madras Medical College. We also have Dr. Prakash M., Associate Professor and Coordinator, Health Data Science Program, School of Public Health, SRM Institute of Science and Technology. Also, a warm welcome to all our viewers. You may kindly drop your questions in the chat. We'll be taking them towards the end of the session. We shall now begin the webinar. I invite our first speaker, Dr. Hari Singh. A brief introduction on Dr. Singh before we start. Dr. Singh is a public health expert with extensive experience in maternal and child health adolescent health, family planning, and HIV programs. He has worked closely with national health programs and supported multiple state governments in strengthening public health systems. He has also held leadership roles in organizations such as Engender Health India and the Foundation for Research in Health Systems, and has contributed to public health education and training in India. He'll be speaking on key public health challenges in India, including the urban-rural divide. Over to you, Doctor.
Okay, thank you, Athira. Since India is a big country, so our public health challenges are multidimensional. I'll explain, run through a broad spectrum of public health challenges which we face in India. You know, when a woman gives birth to a baby, she's at a very high risk of developing complications and dying also. When 1 lakh children are born in India, 80 women die in that process. Just 3 decades ago, 300 women were dying. So a lot of progress has been made over these years. But the tragedy is that most of these deaths can be prevented, which is very much evident from the fact that in developed countries, maternal mortality ratio is less than 5. So 5 compared to 80, it's a big number. Among the children born in India, virtually 1/5, 18 to 20% are low birth weight, premature. And these weak babies, their immunity is low. They are at a high risk of developing infections and even dying. Why so many premature children are born? It's mainly because our girls marry, 1/4 of our girls, around 23% girls get married before 18 years of age. And to add to the problem, virtually 50%, half of our girls and women are anemic. So when undernourished girls at a young age gives birth to a baby, they are premature and they further develop into weak adults, and when they also get married early, and that vicious cycle continues. So it's really challenging to break this cycle. Among the children who are born, virtually 3% children die before seeing their 5th birthday. Why? They develop infections such as pneumonia and diarrhea. It's ironic that we lose around 1 lakh children from pneumonia and around 60,000 children die from diarrhea. Lot of progress has been made in last 15, 20 years on immunization of the children. We presently 75, 76% of our children are fully immunized. And about 8, 9 years ago, we introduced vaccines for pneumonia and diarrhea. And we were expecting sharp drop in the deaths due to these 2 diseases. But unfortunately, that process is very slow. This needs to be examined. Besides this, other vaccine preventable diseases like diphtheria, measles, mumps, whooping cough, they have considerably reduced and are virtually in our control. Another big problem which we face in India is that 1/3 of our children are stunted, which means out of 3 children, 1 child is short in height as compared to his counterparts, normal healthy counterparts of the same age and sex. 1/4 of our children have low weight, and their muscle mass is lower. So it's a big problem, particularly when we see in the context of global situation. Even in some of the poorest sub-Saharan countries, this situation is not as bad. And unfortunately, over many, many decades, there has not been any improvement on this front. So this is a big challenge. Then when our girls are adolescents, they face problems in their menstrual hygiene, poverty, ignorance, stigma related to menstruation, availability of facilities, privacy to change their the sanitary pads, all this in the homes, even in the schools, it's a big problem. And poor menstrual hygiene contributes to the causation of cervical cancer at a later stage. Cervical cancer is second most common cause of cancer in women in India. Uh, then they face the gender-based discrimination, which is again a big problem. And among boys, they get indulged in substance abuse. Um, Tobacco, virtually 1/3 of our men in India consume tobacco, and 1/4 of our men, adult men in India, consume alcohol, which is again a big problem because of this tobacco chewing. We have a huge burden of oral cancer, and virtually no other country comes near us as far as oral cancer is concerned. We have a huge burden of infectious diseases, and TB is particularly notorious. 1/4 of the entire globe's TB burden lives in India. And every year we get around 26 lakh new cases of TB. Uh, we spent around 10,000 crore rupees in the treatment of these cases. But the key challenge is that drug resistance is emerging very fast. Presently, among the new cases, only 4% cases are drug resistance, but among the cases who had received earlier treatment, virtually 25% of them have got drug resistance. And this drug resistant cases, they require higher level drugs which are expensive and have no side effects. And the infection which they transmit to other people is again a drug resistant variety of the bacteria. Not only in TB, in other domains also drug resistance is increasing because of indiscriminate use of antibiotics. Many other diseases, we have been successful. We have eliminated polio. We have eliminated neonatal tetanus. We have eliminated some diseases like leprosy. Yes, leprosy has been eliminated from the country as a whole, but there are some pockets in Bihar, UP, Jharkhand, Chhattisgarh, which still harbor leprosy cases. Diseases like HIV is fast reducing. Filariasis, Kala-Azar, they are reducing. Malaria and dengue are also within containment to some extent, but that's happening at a global level. And these vector-borne diseases have a capacity to bounce back whenever they will get the favorable circumstances. One of the major big problem in India is the emergence of non-communicable diseases, that is diabetes, hypertension, heart diseases, cancer, obesity. We all have seen the COVID pandemic coming. It came, it engulfed the entire country, and then it receded. Similar type of epidemic of non-communicable diseases has engulfed the country, and unfortunately, we are not able to see it. 15% of our adult men have got diabetes, 25% have got hypertension. Heart diseases is the most common cause of death of people, followed by chronic respiratory diseases. So it's a big problem. Lifestyle it's contributing to causation of these diseases, and the pace at which they are growing is very, very fast. Mental health is another problem which is increasing. One more thing I would like to add here, that the infections, the child deaths, the maternal deaths, all these problems are more in rural areas as compared to urban areas. But very interesting thing is that when we come to non-communicable diseases, the gap between urban and rural is fading very fast. It's a difference of just 2 percentage points. Mental health is a urban problem, and it's more in urban areas, and it seems to be increasing. The panic attacks among college students, depression, suicides in higher education institutions are a matter of concern. Road accidents, it's a big problem. The the traffic and the speed of the vehicles is continuously increasing, and every year we lose 1.8 lakh cases on the roads. Environment is coming up as a big menace. We all know air AQI level reaches to 500 in Delhi. So people who have got asthma, who have got allergies, who have got heart problems, their problem is particularly potentiated by this air pollution. Water is very badly contaminated. All our sewage lines, they drain in the rivers. And fortunately, we have got some partial immunity and we are able to manage. But when people come from outside the country, some of them face a really difficult time consuming our food and water. One important aspect is healthcare, access to healthcare. There's a contrast between rural and urban areas. All the hospitals and healthcare facilities are concentrated in the cities. So public facilities are overcrowded and private facilities are very expensive. And it's irony that virtually 39% of our health expenditure comes out of the pocket of those who became sick and they availed treatment mainly from the private hospitals. So these are some of the major key public health challenges in India.
Thank you, Doctor. Thank you for clearly outlining the challenges, highlighting the need for preparedness, and setting the context for the discussion. Next, it is my honor to invite Dr. Soumya Swaminathan. She is a globally recognized public health leader. She has served as Chief Scientist at the World Health Organization and as Director General of Indian Council of Medical Research under the Ministry of Health and Family Welfare, Government of India. With over 4 decades of experience, her work is focused on tuberculosis, HIV, and strengthening global health systems. She has also played a key role in coordinating scientific efforts during the COVID-19 pandemic. She will be speaking on pandemic preparedness and more. Over to you, Doctor.
Thank you very much, Atira. Good morning and good afternoon, everyone. It's a pleasure to be on this webinar, and Dr. Hari Singh has given a very exhaustive overview of the public health challenges facing India. Before I talk about infectious disease outbreaks and the threat of pandemics, I'd just like to add a word on the threat of climate change on health, which I think is going to cut across all of the different areas that Dr. Hari Singh mentioned, because climate change, of course, means that there are going to be more unpredictable weather patterns, more extreme climate events like extreme rainfall, floods, landslides, etc., but also prolonged heat. And along with air pollution, these are going to be the major threats to health. And if you really look at the analysis that the Global Burden of Disease does in terms of risk factors, dietary risks, that means unhealthy diets, which account both for undernutrition as well as obesity and micronutrient deficiencies, and the role of pollution, air pollution, both due to outdoor and household air pollution. These are the top risk factors which really are already driving a lot of the NCDs and will continue to drive the NCD, plus the direct impacts of heat on people and their health can result not only in deaths due to heat stroke during the extreme heat events, but also a chronic impact on the cardiovascular system in particular. And there's recent evidence to indicate that there's accelerated aging that may occur because of prolonged heat exposure. We have also been doing some work on looking at the impacts on women in particular, And it's clear that there's a disproportionate impact of these climate hazards on women. They do face a disproportionate burden. And there are several reports which are on our website, on the MSSRF website, that you can refer to on this topic. Now, climate change is also driving a change in infectious diseases. And for example, the pattern of vector-borne diseases, geographic spread is changing because the vectors can now survive in areas where they did not survive before. For example, the spread of malaria in areas where malaria was not seen, dengue, which is the fastest spreading vector-borne disease globally, because the mosquito, the Aedes aegypti and albopictus, are very well adapted to urban settings, and also diseases that are tick-borne, that are borne by mites and so on. Scrub typhus is a huge problem in India, totally unrecognized and underdiagnosed. So with climate change will also come new vector-borne diseases or new areas. And then, of course, the infectious disease threats, which are coming from zoonotic sources. WHO predicts that 75% of new diseases are going to come from zoonotic, and that the frequency of the jumps from animal to human is likely to increase in the future. We have seen in the past 7 pandemics or 7 what is called the public health emergency of international concern, PHEIC is the terminology used by WHO. Mostly were influenza in the past, but then of course we've had Ebola, and we've also had Nipah was not a public health emergency of international concern because it was much more localized, but we've had SARS-1 and MERS and SARS-2, CoV-2, which was of course the most recent pandemic. So coronaviruses are again a group, and there are about 30 groups of mostly viral, but some bacterial pathogens, which are identified by WHO as potential pandemic threats. So, of course, when we faced, we have had in the past, many outbreaks, localized infectious disease outbreaks, and we also have tuberculosis, for example, can be considered a pandemic. HIV can be considered a pandemic, but these are more sort of longer term or chronic diseases. What are the lessons that we learned from COVID, and where do we need to strengthen our response? And this is where I think it's also important for young people, because the future careers could be in these areas. Public health is a very important area, which is going to need more and more focus, more and more emphasis. It's getting more complex as well. One big area is around data. One of the things in COVID was, how do you capture the data accurately in real time? And the challenge was that there are multiple data systems. The government, of course, created the Arogya Setu app, and then the COVID app was there for vaccination. Digital architecture is very strong in India, but somehow in the health field, that's not yet being fully utilized to give us real-time information. So there is the IHIP, which collects data from all of the health centers across India. There's also HMIS, which is used in hospitals to collect health information. But how do you bring these together? And now using AI, one should be able to analyze in real time the health data which is being collected, whether it is on outbreaks, whether it is on chronic non-communicable diseases, road traffic accidents, whatever it is. Policymakers need to be able to look at data in real time to be able to change. So we need very good health data scientists, and I'm glad that Dr. Prakash is there. Similarly, we need biostatisticians. So India's had such a strong history of science, of mathematics and statistics. But when it comes to biostatistics, there are far fewer people. So people who understand biology and mathematics, who can apply to biostatistics, goes very closely with epidemiology to again gain insights into the changing disease patterns, so that we can our policy can move side by side. So I think data surveillance, including things like wastewater surveillance, which we started doing. So using technology, genomics, genomics has really advanced in the last few years. The technology has become more affordable. It's become easy to use. The equipment is becoming more affordable. But again, it's large volumes of data. And so during COVID, we had the INSACOG that was set up, again, to network the different labs that were doing genomic testing, and then come up with tracking the variants of SARS-CoV-2. Now, we have so many infectious diseases, and if we can use this type of genomic lab networks, we can study tuberculosis, we can study dengue, we can study antimicrobial resistance. So many pathogens can be tracked and studied, and we can get a better understanding of how these diseases are changing, and also how our policies are impacting them. Are they going down, going up? And they can give us early warning also of that's what wastewater surveillance was being used in COVID, to give a signal that COVID may be spiking in certain areas. So I think use of genomic and biotechnology tools to help public health is another emerging area. And then the third area is, of course, in R&D, in creating diagnostics, new therapeutics, as well as vaccines to deal with existing and emerging infections. And during COVID, we saw the emergence of mRNA, of DNA platforms, of nasal vaccines, of multi-antigen vaccines. So this whole area became so exciting, vaccine development. And today we can use the mRNA platform to develop monoclonal antibodies and to develop therapeutics for non-communicable diseases. So the platforms that came to the fore during the pandemic today give us an opportunity, and India can be a leader actually in biologics and cell-based therapies. In fact, the recent budget announcement by the government of the Shakti program, a 10,000 crore investment into biologics, basically R&D, is meant to really give more impetus to innovation, because India has been a leader in generic pharmaceuticals, both in vaccines and in small molecules. So but in the future, I think we have to be leaders in innovation. And if you look at new drugs being registered around the world, India just accounts for 2% of new pharmaceutical products, whereas China accounts for almost a quarter of pharmaceutical new products today in the world. So they've overtaken America as well. So India can be a leader in innovation. And so we need people with technical skills and a strong research interest in going into, and as Dr. Hari Singh pointed out, NCDs are going to increase, cancers are going to go up, and there are exciting areas of research and product development to address. So both infectious diseases and non-communicable diseases, sometimes using similar platforms, but focusing more on biologics. And side by side with innovation, we're going to need strengthening of the regulatory system. India is investing more in the CDSCO now, the Central Drug Control Authority. And we are going to need lots of regulators trained in regulatory science and quality assurance and safety and efficacy in new areas of innovation and therapeutics. And because without regulatory science growing hand in hand along with industry innovation, we will not be able to actually become world leaders in pharmaceutical space. So I think I'll stop there, and of course we'll be able to take Q&A later. Thank you.
Sure, doctor. Thank you so much. Thank you so much. Especially for explaining the many risk factors, lessons, highlighting how to prepare, and of course the careers in public health. Our next speaker is Dr. Amal Pavanathan. Dr. Amal is a senior vascular surgeon and former director and head of the Institute of Vascular Surgery at Madras Medical College. He played a key role in developing Tamil Nadu's organ transplant programs, widely recognized as a model across India. He currently serves as a member of the State Planning Commission, Government of Tamil Nadu. He will be speaking on preventive care and steps taken by the Tamil Nadu government. Doctor, please go ahead.
Good morning, and thank you, Ms. Johnson, for your kind introduction. First of all, I must thank Dr. Hari Singh and Dr. Swaminathan. Dr. Hari Singh has laid out all the challenges that we face in public health in India and in Tamil Nadu. And Dr. Swaminathan explained that not only the global challenges in public health, but also the opportunities that the young people have in public health, in research, innovation, and digital technology, as well as regulatory mechanisms, etc. So, the future for professionals in public health is certainly going to be much more challenging than the previous eras. And Dr. Swaminathan did well to explain uh, to the youngsters so that youngsters can take up public health as a specialty. Dr. Swaminathan was a pediatrician and became a public health specialist. I am a vascular surgeon and became a public health specialist, because all of us have realized that single disease or single organ specialty will address only part of the problem, and we will have to look at the problem as a whole. So public health is the only way to look at the problem in a holistic way. So I will confine myself to the topic, which is public health in India from reactive care to preventive ecosystems. And I will confine to the efforts taken by Tamil Nadu government, not just this government, from 1930s itself, and along with the central government, all the preventive healthcare efforts taken by successive governments, which has now led to a very impressionable achievements in IMR, MMR, and other vital indicators. So, as you know, that all of us know that it's common sense that prevention is the most cost-effective way in public health or in health. Now, if you invest 1 rupee in public health, you get 9 rupees in return by various other means. So, society definitely gains much more by investing in public health measures. This is globally acknowledged. Therefore, our demand had been consistently to both the government of India and to the state government is to increase the investment in public health. So last budget, Tamil Nadu government increased about 8.4% specifically for prevention of NCDs, which is a welcome step. I would like it to be more, but this is good enough to be recognized and appreciated. As you know, Tamil Nadu had a Public Health Act from 1930s. It was the first in the country to recognize public health as a necessity, and enacted in 1930s. So from potable water to vaccination to epidemic surveillance, the crucial efforts taken by public health specialists using the Public Health Act had been one of the most instrumental factors in helping Tamil Nadu to reach a very good stage in public health. So to come to the programs in Tamil Nadu, most of the programs are Tamil Nadu centric, but also been helped by central government. And this is not just this government. As I said, this is from 1930s, 40s. So right from birth up to 2 years, the nutrition package is now well taken care of by ICDS, mothers and children, and the child nutrition continues till 5 years. You know, regular weight is taken, regular indicators for stunting and wasting is taken, and specific measures are being taken to address any kind of wasting and stunting in childhood. The ICDS system takes care of it. And then once the child enters the school in 5 years, it enters a school health system run by government of Tamil Nadu. Every year it includes eye checkup and ear checkup and mental health checkup, and monitoring height and weight, and wherever there is deficiency, steps are taken to correct them promptly. This is about school health system, and we have introduced, as you know, breakfast scheme in addition to the well-running noon meal scheme. So this is to take care of the nutrition of the children and to ensure that no child comes to school hungry and fasting. So breakfast scheme is now well appreciated. It is started with the government schools. Now it's going to be extended to government aided schools also. It's serving the vast majority of children who need good nutritious food in the morning. And in the evening, we have what is called Illam Thedi Kalvi. This is to retain children in the evening hours when both parents are working and come home late after farm work, etc. So to identify these children and locate them in safe place and give them extracurricular activities and cultural activities is to make them more productive and prevent them from going astray. And this is also a well running program to retain children in the educational sector. And as I said, and as Dr. Hari Singh explained in the beginning, stunting and wasting has been very refractory throughout the country and in Tamil Nadu too. It is a major public health challenge, I would say, and we are trying to address it as earnestly as possible. Uh, we have tried every method, including annual deworming and all, but still this problem remains refractory. This is subject to still more researches and still more active steps to be taken. And then when it comes to girl children, we start very early tackling their anemia, diagnosing them anemia, and regular supply of iron and folic acid. I agree with Dr. Hari Singh. In spite of pumping iron and folic acid for the past 20-25 years, the anemia rate in adolescent girls in pregnancy is still quite refractory. It's still concerning, and we are looking at it seriously. Certainly, we hope to bring it down as early as possible, but it is a challenging scheme. Once a woman becomes pregnant, she enters Muthalakshmi Reddy scheme, where around 18,000 rupees cash transfer takes place in installment, in addition to regular checkup, especially for hypertension, diabetes, to prevent gestational diabetes and preeclampsia, etc. And we also make arrangements for safe delivery, especially in very inhospitable places and hilly areas. We shift them well in advance to a good place for a safe delivery for both mother and child. Today, I think 90% 95% of the deliveries are institutional deliveries, ensuring safe motherhood and safe delivery. We also have equipped many hospitals with neonatal ICUs so that no child will die of lack of medical care immediately after delivery. So this is the way we take care from childhood to adolescent girl to a woman delivering children, and then adequate vaccination for all children. And today I think Tamil Nadu vaccination coverage is upwards of 90%, which is higher than the national average. And then I come to what is called Makkalai Thedi Maruthuvam, that is the medicine going to the doorsteps of people in every village of the state, in every small town, village, etc. Initially, it was started to target people who are more than 40-45 years and who are bedridden and who cannot come to the nearest PHCs for various reasons. And we initially started with diagnosing and treating diabetes and hypertension. Now we are expanding it to cervical cancer, offering physiotherapy wherever it is needed, offering home dialysis to those who suffer from renal failure but who cannot go to major centers for hemodialysis. So this helps quite a lot of people, and we are expanding it so that it will cover even detection of cervical cancers and other diseases. One part of Makkalai Thedi Maruthuvam is Padam Kapum. So one of the major complications of diabetes, as all of you know, is diabetic foot. So now there is a state-wide program, mostly in medical colleges, but also now into districts and taluks, where in addition to eye checkups to diagnose diabetic and hypertensive retinopathies, we also have special foot care clinics, podiatry clinics, where early neurological changes in the foot are diagnosed, adequate foot care is advised, wherever necessary, specific footwear is supplied, and so we prevent early ulcers in the insensate regions and prevent amputation, which is one of the major morbidities in diabetes. The problem with diabetes is if you are undergoing one amputation, within 1.5 years, the other leg also gets involved, and they go for bilateral amputation. So to prevent this serious problem, Padam Kappam is now instituted all over the state, and in every PHC now, every person above 18, their urine sugar is monitored, urine proteinuria is monitored, BP is checked up, and all the records are available. So we diagnose early proteinuria and early glycosuria, so that diabetes, hypertension, and early renal failures are treated. This is in addition, as I said, about diabetic retinopathy, and we have special camps for cataract. So cataract persons who cannot come to the hospitals are taken care of, screened there, and then the government brings them to the hospital and treat them. One more program is Makkale Nalam Kakum Stalin. That is, we have taken primary health care to the people. The second step is to take tertiary medical care to the people. So in this program, camps are held where all the super specialists go to the villages or go to the designated centers and screen people for diseases, and wherever such diseases are found and they need treatment, they are transferred to the hospital. So in addition to public health and primary health care, we are now trying to take tertiary health care also to people in a large way. So these are some of the programs. Some more things we have realized is that taking primary care, tertiary care is different, but other things like good education. The one problem Dr. Hari Singh said was teenage pregnancy. So the one way to prevent teenage pregnancy is to see that there is not a single girl who drops out of school or college. So we are trying to ensure that every girl who finishes school enters some college, so that marriage age can be postponed. This is the actual real reasoning behind ensuring gross enrollment ratio in our state. So to ensure that every girl child enters college so that marriage age can be postponed. We are also very concerned, as Dr. Soumya Saminathan explained, about global warming and heat strokes, etc., that it's not just medicine. People need to have safe housing, safe water supply, very good environment, assurance for a job, salary, and good nutritious food at home. So unless we focus on all these things, our public health focus cannot be complete. And I think I will stop here. Thank you very much, Dr. Johnson.
Thank you so much, Doctor. Thank you so much for your valuable insights. We move to our final speaker, Dr. Prakasham. Audience, if you haven't already dropped your questions in the chat box, feel free to do that. We'll be taking it after Dr. Prakash's presentation. I would like to introduce Dr. Prakasham. Dr. Prakash is an associate professor and coordinator of the Health Data Science program at the School of Public Health, SRM Institute of Science and Technology. His work focuses on epidemiology, biostatics, and the use of data science to strengthen preventive healthcare systems. He has worked with institutions such as the Public Health Foundation of India, the National Institute of Epidemiology, and the Indian Council of Medical Research. He'll be speaking on the role of AI and digital tools in public health today. Over to you, Doctor.
Thank you, Atira. Very good morning to everyone, and I think we have heard very insightful messages, information, and discussion on India's public health system, how world revolved around the public health and the importance of public health from Soumya ma'am, and Dr. Hari Singh has explained about the challenges in public health, and I think Amul Raj sir has explained very well about like what are the programs which Tamil Nadu government has been running from the initiation, and what are the activities taken care. And now like after all this, if I want to speak, so what I would like to focus is on the next step, like how do we make these systems. I think there are large systems A lot of systems has been established, programs has been established. And how do we make this system smarter, like using AI and digital tools? So India is not going to start from zero now, because it is already started. Like the digital tools has been established long back, and we are already having strong digital foundations. So the real shift now is from data collection to how data driven decision making can be taken. So that's what where we need to look for. So India today has a strong digital health backbone under the government scheme National Digital Health Mission, like Ayushman Bharat Digital Mission, where I think around 86 crores of ABA IDs has been created. And now in Tamil Nadu especially, we have all the health facilities, they are linking up the patient's data with ABA ID, linking that with ABA ID. So where the tracking of the patients is very much possible, right? And more than 90 crore digital health records has been linked already. And I think 2.5 lakhs of health facilities has been linked with this. So where the patients go to different facilities, the patients can be tracked. So the data from this can be used using AI, so which will help for prevention activities as well as for prediction. So platforms like eSanjeevani have already delivered millions of teleconsultations, especially in rural areas, which I think earlier Dr. Hari Singh sir or Soumya ma'am already discussed about the split between rural and urban, where there is a need. I think this has already reduced the gap between rural and urban. So digital tools is not a pilot here anymore. It is already a population level scaled digital infrastructure we have established. But infrastructure alone is not enough, right? So the next step is like how intelligent we can able to use through the use of AI. So AI is transforming public health in four key ways that which I can see. One is like early detection. The second one is for decision support, and third, like better access through telemedicine, and at last, like public health intelligence. So early detection, we all know that there is Cure AI, which as like one of the example is Cure AI, which is already being used for detection of TB. Just by chest x-ray, it can able to prioritize like high risk patients. So okay, and as I'm little bit to make you people aware, like AI is not going to replace the doctors or the care provided by the physicians, but it should help, and it is already helping to for them to take decisions. Okay, so that's why decision support system AI supports doctors and health workers to do works faster and more consistent decisions, because even the senior most person can able to take decisions or correctly diagnosing is very much possible with their experience, whereas the new freshers to take informed decisions like without any error, these AI tools can help them. So better access through telemedicine, like telemedicine is already solved, or access the problem of access problems has been resolved. Now AI improves it further through triage and prioritization and follow-ups, especially making more the care efficient at scale, right? So public health intelligence AI can predict outbreaks, optimize the resources, and support policy decisions. So that's what we need now. So rather than reactive healthcare, we can go for predictive healthcare. So that's how I think Soumya ma'am has highlighted very much that the data which we are generating has to be used efficiently, that can predict and as well as prevent the future problems. So Indian case, like we already have TB screening tool through Cure AI, and I think recently the Gates Foundation, which has done in December 2025, I think, right? I think around 6 inventions has been showcased, where one of that is mobile based AI, using AI they have scanning. So the ultrasound, which can be like previously it is only for tertiary care level or secondary care, so even now this can be taken to the primary care, right? So the scan now it is with the mobile handheld devices that can able to do scanning. So that is one of the main invention showcased in this 2025 in the Gates Foundation. At the same time, so breast cancer screening again using Niramai Health Analytics. And even Aravind eye care system, they have started using AI, like eye disease screening through AI system. So these are all not pilots, these are already working. So working systems improve early detection and access in real care settings. So I'm not just trying to promote the AI, but yes, there are challenges with AI. Okay, so like data quality, the systems has been created, but whether it is integrated to see like longitudinal, so how that can be able to, like, unless we have more data and it is linked together, we cannot able to use it, right? So that's why we can, like, there is already lack of interoperability. So even though our interoperability, I think with ABA and digital national digital health mission, yes, we are trying to overcome each one step by step. What next we need is workforce readiness. So the young generation, the next students who used to learn public health, they have to be more with digital health systems, and they should be ready to learn about how AI can be used to resolve all these public health problems. Not all, but through each of these problems has to be resolved, and where how efficiently we can use AI. That is what we have to do now. So trust in AI systems, yes, it will be slowly, the trust will build. I think this is one side is a positive, and other side we can see it is a negative, where people started using AI based decisions or AI based support they used to take for primary care. So right, that has to be carefully done. So the real bottleneck is not AI itself, it is the health system readiness and the workforce readiness. So with this, I want to conclude, like, AI will not replace public health system, but it will fundamentally transform how we work. So for India, the goal is not just innovation. So now each digital infrastructure or the AI tools which it is going to develop, it should start thinking in terms of scalability, and also it should be linked with the existing system rather than standalone system. So that's how it will impact the real public health needs. So I think rather than treating disease mostly, so we need to do like predicting for preventing the disease. So at a population level, that will have a real impact. So I think with this I will stop. Thank you for the opportunity, and I think we will go for more discussion. Thank you.
Yes, Doctor. Thank you so much. Thank you so much. We shall open to the discussion. I am already looking at many questions. We do have many follow-up questions. Many are directing to what if a student wants to work in public health, where should they begin? That's I can see many questions on the same line. So I'm taking that one as the first one. If a student wants to work in public health, where should they begin?
Maybe I can start by saying that it's a good idea to volunteer or intern in different institutions, even during your student days, so that you get an idea of what kind of work can be done in, say, a government organization or an NGO or an academic center. And I think for public health, it's very important to get on the ground experience as to what is the lived reality of people. So there are many NGOs and CSOs that work in communities in the health space. And so I think getting exposure, say, during an internship would be very good, because some people are more suited for laboratory-based research. Some people are more interested in community-based work. And to identify your own strengths and your interests, I think you need to have that kind of exposure. And I don't think we do enough of that in India, So the kids really should be using their holidays to intern in different kinds of institutions, ideally something which is outside your comfort zone or the scope of what you have been exposed to so far.
We also have questions on Tamil Nadu model, as in there is a question asking if Tamil Nadu is often called a model, which one is a simple step that has made a big difference?
Sorry, come again.
We have a question asking, Tamil Nadu is often called a model. What is one simple step that has made a big difference?
The
That
simple
can be
step is
seen
that
as a model. Yeah.
the simple step is that Tamil Nadu has invested in public health as I said right from the beginning, and had been consistently doing that for past so many years. So the dividend is now for all of us to see. So I would advise that say this is the Tamil Nadu model, that we understand, realize and enforce the concept that investment in public health is the overall public good measure that prevents many of the diseases, uh, and it reduces out of pocket expenditure, etc. So invest in public health.
We have already touched upon this, but I'll still take it up. There's a question asking, can telemedicine help rural patients? For example, what kind of cases can be handled remotely?
Telemedicine is being widely promoted through the e-Sanjeevani platform, where because of the shortage of specialists in rural areas, it is now possible for a primary healthcare center doctor, and in some cases, some states, even directly the CHOs and the sub-centers, health and wellness centers, are able to make an appointment with a specialist and connect the patient to the specialist. Now, obviously, this is a lot of savings in time and money for the patient, who doesn't have to travel a long distance, and particularly if you need follow-up and repeated consultations. Similarly, there's a Telemanas program for mental health. And so I think telemedicine, direct doctor to patient, that is one model. But the other model is also capacity building of doctors, let's say in remote and primary health centers, who don't have opportunity to attend CMEs or who are not in an academic institution. Using the ECHO platform, NIMHANS, for example, does a lot of capacity building on mental health. And many state governments now use the ECHO platform to do that. It's a very effective way of training, let's say, a primary healthcare doctor in how to manage a liver disease, or how to. There are many nuances and many advances that people need to keep in touch with. So I think, again, that's another, with the digital technologies we have today, these provide opportunities which were not there in the past.
We have another question, on a career question, on how can employment opportunities and potentially a mentorship network be created to support public health and health data scientists?
Yeah,
Okay,
as
I'd like to
Dr.
take this
Soumya
question.
said, they should look for internships. Now, there are a large number of national and international NGOs, corporate social responsibility initiatives, government departments. They engage these public health professionals, and they can get hands-on experience, and even they can get jobs in these organizations.
Ms.
Okay,
Johnson, can I
yes.
add a little? Yeah.
Yes, please. Yes, please, Doctor.
So youngsters, I would certainly encourage interning with good NGOs to get a better perspective of public health. In addition, I will tell you this thing: look at your own surrounding, look at your own water, look at your own air quality, look at your own housing in your neighborhood, look at your own safe roads, road safety, etc. You study yourself, and that would be the greatest education.
We have many questions on preparedness. I am taking this. During COVID, what was one major mistake India made that we should not repeat?
Well, I think, one has to learn from experience, and most countries faced a similar challenge. It was not India alone. And so, yes, I think mistakes were made. There were some areas where we were very successful, like, for example, in vaccine development and also vaccinating our population. I think we did a tremendous job thanks to our frontline workers. Very quickly, we were able to vaccinate a large percentage of our very large population. I think where we went a little bit astray was perhaps one was, of course, the fact that there were shortages of hospital beds and oxygen, particularly. We realized that at the peak of the Delta wave, when our hospitals were being flooded, we could not cope up with that demand. So health system needs to have the resilience. And also we need to ensure that these basic facilities like oxygen are available even at the first point of contact for the patient. Everybody need not come to a tertiary hospital to receive oxygen. In some countries in Africa, in fact, many children were dying because of pneumonia, regular pneumonia, nothing to do with COVID, because they didn't have oxygen. And it was only during COVID that countries suddenly woke up to the fact that oxygen is an essential medicine and it needs to be available at all levels of the. So many lives could have been saved if oxygen and other emergency resuscitation equipment was there. So I think that is something India took seriously after realizing that this was a problem. Of course, state like Tamil Nadu was able to manage without oxygen shortage. Some states could manage it very well, but many states could not. The other area
Can
I think is yes, please go ahead. I think data
madam.
sharing
No,
was the other one.
You please finish.
Data sharing
please
and
finish.
pooling of data,
Yeah.
that was the other one. There were so many controversies around how many cases, how many deaths. We need a strong CRVS, civil registration and vital statistics, which record birth, death, and cause of death. Until today, we do not have a good system that we can say is 100% recording. Births, I think, is more or less good, but death and cause of death reporting, still there are many gaps in states. Thanks.
Can I add a little bit,
Yes.
Ms.
Yes,
Johnson?
Yes, please, Doctor.
Overall, I would say that the world managed COVID extremely well. And we also learned several lessons. One crucial lesson that I learned, and Dr. Swaminathan must tell me whether I am right, that where there was strong emphasis in public health and hospitals run by the state governments, public health sector, we were able to manage better than a totally privatized healthcare systems.
Yes, true.
Second thing, this is one lesson that I learned. Second was the question of equity in vaccine. We had some countries where vaccines were plenty. We had some countries where begging for vaccines and dying without vaccines. This is another major lesson that I have learned, that in public health emergencies, equity is one crucial factor if we want to arrest the disease early. Thanks.
There are also some questions on AI, more questions on, I think we have already touched upon the examples being used in healthcare, but on how, if there are risk of people being left behind, what is the issue with health data today? Can we take that? The issue, can digital tools help detect diseases earlier? And also, what is the biggest problem with health data in India right now? Are some questions I can see.
I think, hope I'm audible.
Yes, sir.
I think especially I think India has established IHIS. I think ma'am has mentioned that, and we have, and even Tamil Nadu, we have very well established digital tool to track as well as to identify the disease earlier, like which is for screening, disease screening. I think we have very well established disease screening and identification. So that which we have now, it is, we can able to detect earlier. So that screening, not only the screening aspect as well as the disease when it's got spread, and we have the system to detect earlier. So with that, I think one of the positive which I have seen through the COVID is we have war rooms where we have systems with linked with GIS to predict, and predict as well as to act immediately. So that has helped to little bit to contain as early as possible. So even now we have very well established a system for communicable diseases, where we are working with, and to identify the digital tools has been used to create the buffer using GIS tools, and based on that buffer, the health system of Tamil Nadu as well as the India, everyone is working to contain the disease as early as possible.
Thank you, Doctor. We also have more than 5 questions on the programs and placements at SRM. Can you? Yeah.
Yeah, programs. We have 5 programs, At undergraduate level, we have a MPH integrated program. After 12th standard, students can join this program. After 3 years, they get BSc public health degree, and then if they continue for another 2 years, they get MPH or master's level degree. Then we have Masters Public Health MPH program. These 4 programs are postgraduate programs, 2 years full-time program after graduation. In MPH program, our focus is on understanding the health problems of a community, measuring the burden of the disease, formulating strategies, designing a project to address these problems. And then we have a program, MPH Applied Health Research, where the focus is on research, how to understand the root cause of the problems, how to understand which interventions or projects are effective, how much is the effect. We have a program on MSc Biostatistics and Epidemiology. And in this program, again, focus is on research and data analytics. How large data can be analyzed using advanced statistical softwares. And the last program is MSc Health Data Science, where we learn these emerging technologies of AI, deep learning, machine learning, new techniques of algorithm, modeling, projection making. So these are some of the programs. And then we have a PhD program for those who have done post-graduation.
Thank you, Doctor. We are coming to the end of the discussion. I would still like to take one question. There are many students asking what is one skill that you think every health professional should have today. I would like to end with that question.
One important skill is communication skills. The students should be confident. They should be able to speak clearly. They should be able to listen to other people, understand their perspectives. Maybe other panelists can add.
I was also able to say that ability to listen and to be able to communicate simply. But since Dr. Hari Singh has already said that, the other skill I would say is the ability to read an article or a research paper and be able to find out the strengths and weaknesses, particularly with respect to the methodology. Because today what happens is you'll see many things being claimed on social media by many people. What is the evidence base behind it? Is it a strong evidence base or not? So I think that ability to look at data and to understand, so you have to understand a little bit of statistics to know whether when somebody is claiming something, has it been properly studied or not.
So I would say that the students must have one scientific temper in the holistic sense of the word, critical thinking and appraisal of whatever they study or learn or whatever they are being lectured to, and above all, empathy. These are the 3 characteristics that I would like in every student, and they will definitely succeed well if they have all the 3.
Just to add one more, like I think it is same, but they should try to understand from their surroundings. I think which Dr. Amulraj already mentioned. So from the community, what is the problem that should be understand or taken from the community? Then they have to realize. Then they have to analyze, like from the literature, what is happening. So whether critically appraise whether the information from the literature is right or wrong, they should be able to bifurcate between that. They have to understand very clearly. Then based on the problem as well as the existing evidence, they have to create their with some analytical knowledge, analytical thinking, they can able to come out with the solutions. That's what we expect from public health perspective. Thank you.
Super. That was great. With that, we are ending the webinar. Thank you so much to all our speakers for sharing their time and insights. Thank you to our audience for joining and engaging with us. That brings to the end of the discussion. Thank you so much, doctors.
Thank you, Ms.
Thank you so much,
Johnson.
everyone.
Thank you. Thank you.
Thank you, Ms.
Thank
Johnson,
you.
and thank you, fellow panelists. Thank you very much.